So, why in the world would we give drugs to drug addicts? Well, you'll be happy to know that in the early 1900s, there was a law passed. It's actually a federal law called the Harrison Narcotics Act that made it a federal crime to treat an opiate addict with an opioid to treat their addiction. Now, why would they be doing that in 1919? Well, it turns out there were a lot of opium addicts that were, the railroads were being built, and there was a lot of opium coming over from China. And doctors were actually treating these opiate addicts with morphine, interestingly enough. Not particularly what I would recommend today, but they were having some decent results and they were keeping people alive. But apparently that didn't jive with the current culture of sort of an abstinence-based lifestyle back then. And so they made it illegal. In fact, they made it a federal crime to give an opioid to an opioid addict to treat their addiction. Now, we do that today. How are we able to get away with that? Well, I can ask for permission from the federal government to do it, as do all doctors who treat opioid dependence. And we get a waiver so that we're allowed to do that. But why would we do that? It doesn't make any sense, right? Aren't you just substituting one thing for another? And this kind of pokes at the topic of medication for use in substance use disorder. Do we use medications? Why do we use them? What are they good for? Well, substance use disorders are diseases, and most diseases have some form of medical treatment available, and that involves prescribing medications to patients, and that's exactly what we do here in treatment. As an example, for opioid dependence, and that involves people who are using oral opioids like oxycodone and hydrocodone, or fentanyl nowadays, or heroin, which we don't see nearly as much of as we used to. It's mostly fentanyl these days. We use a medication called buprenorphine, brand name Suboxone or Zubsolv, and buprenorphine is an opioid. It's what you might call a weak opioid, and so it actually partially binds to, but it also partially blocks the receptor in the brain that's giving the euphoric response. So patients who take this medication don't experience anything in the way of euphoria, but what they do experience is an elimination of the craving, the overwhelming urge, desire, and compulsion to use an opioid. And so that's what it does. And the most common reason why people are unable to stay in recovery when they are opioid dependent is that the craving is so powerful they can't stop using, and so they continue to use. And so these medications give patients a chance to get started in recovery and develop a strong recovery program without having to deal with the overwhelming compulsion to use opioids. That's why we use that particular drug, buprenorphine. It's used only in opioid dependence. It's not effective for any other class of drugs. We also use another medication for opioid dependence, and that's called naltrexone, and that is available as a once-a-day pill or as a once-a-month injection, and we use both those medications here at Chapel Hill. And the brand name is Vivitrol, and we use the injectable naltrexone regularly in our opioid-dependent patients. It treats cravings, but it's also an opioid blocker, so if they happen to use any opioids, they get no effect from them. But interestingly enough, that opioid blocker, naltrexone, was approved for use in patients with alcohol use disorder long before it was ever used for patients with opioid use disorder. And that's because it turns out that the craving suppression for alcohol use disorder patients was quite remarkable. More than doubles the likelihood that someone will remain abstinent from alcohol in a year. So we use it almost universally in our alcohol-dependent patients. And has to do with the way the opioid craving is generated. There's opioid receptors involved in that pathway, and blocking them seems to reduce the craving process. And so we use that medication in patients with both alcohol use disorder and opioid use disorder. We also use a drug called gabapentin, which has a very bad street reputation. People say that, no, you just use that to get high, and it's a bad drug, and pharmacists want to eliminate it because they think it's worse than heroin. But gabapentin actually has quite a bit of scientific literature behind it, demonstrating that using that drug dramatically reduces relapses and improves outcomes in patients with alcohol use disorder, for example. It also works with cannabis use disorder quite well. And what it does is it kind of helps balance some of the brain chemistry, reduce what we call the protracted withdrawal syndrome, and generally create a calming effect in these folks who are agitated and irritable in early recovery. One very prominent study showed 1/4 of the number of relapses in the gabapentin group. That's a huge advantage, and one of the reasons why we use that medication regularly in our patients here at Shepherd Hill. And the last medicine we use is one that doesn't get much use at all, and that's called N-acetylcysteine. Some of you may have heard of that, some of you may have not, but N-acetylcysteine, is actually a amino acid precursor. That means it's basically a protein supplement. It didn't actually used to be a drug. It used to just be a over-the-counter supplement. It's been tossed about as being an actual medication, and we now write prescriptions for it. But that also has some brain balancing effect. If you're interested in the science behind it, it is a glutathione precursor. And glutathione is one of the brain chemicals that's involved. And producing a little bit more of that brain chemical helps settle some of the cravings associated with stimulant use. So for the first time, we have a drug that's effective in reducing those cravings from methamphetamine and cocaine use disorders, and we find a dramatic reduction. In my experience here at Shepherd Hill, we probably see someone on the order of 50% or more reduction in cravings for stimulants, which is really the first time we've ever had anything that was that effective at treating these folks. There is some data out there on it. It hasn't been studied extensively because it's not a branded drug, and there's no money to be made in promoting it. So, but we use it quite extensively. So we're very comfortable using medications in a lot of different classes here at Shepherd Hill to treat substance use disorders, and that's really, in our opinion, one of the pillars of treating this disease. Patients who need these medications get them while they're here, and we use them very responsibly. Now, unfortunately, there's a great deal of irresponsible prescribing out there. I don't want to spend too much time talking on this, but there are a number of treatment programs and providers out there who will write prescriptions for Suboxone who know nothing about substance use disorders, and that's unfortunate, but that's just the way it is. And we try to get those patients away from those providers and get them into the effective treatment that they get, because the medication by itself is insufficient when it's not combined with effective treatment, and that treatment is in the educational variety that we do here at Shepherd Hill. But a lot of people are looking for that easier, softer way. It doesn't work, but a lot of people want to try that for a while. And that's all I got to say about that.